Okay, let's dive into this stack of sources you've brought us. We're taking a deep look at, well, a really important shift in healthcare, haven't we?
We have indeed.
It's about how doctors are approaching the care of older adults who get diagnosed with cancer.
Hmm.
For a long time, it felt like those treatment decisions were often pretty heavily weighted, maybe even, dominated by just one number, someone's age.
And that was really the core problem, wasn't it? Relying mainly on chronological age and perhaps a basic measure of how active someone is, like the Karnofsky or ECOG performance status.
Right. Those scores basically just look at how much help someone needs day to day.
Exactly. And the critical insight that began to emerge is just how incredibly diverse older adults are. Age alone is just a very poor predictor of someone's underlying health, the resilience, or critically, how they'll tolerate cancer treatment.
So this deep dive is specifically into the evolution of what's called Geriatric Assessment, or GA, in cancer care.
That's right, GA.
We're going to trace that journey, what it is, why it became, essential, how the evidence built up to support it, and sort of where we are now. Our mission really is to unpack the key stages of this evidence, right? From just recognizing there was a problem.
Yeah, the initial aha moment.
To actually proving that taking this different approach using GA makes a real difference in care and outcomes.
Exactly. It's a story of moving from a kind of one-size-fits-all mentality based largely on age to something far more nuanced and ultimately much more effective for the patient.
All right, let's start where your sources do, back in the 1990s. This period, they often call it the awakening. Seems fitting.
Yes, the 90s were absolutely fundamental because this was the time when the medical community really started, I think, acknowledging the severe limitations of the existing system.
The age-based system.
Yeah, they saw that just looking at age and that basic performance status, it just wasn't capturing the whole picture for older cancer patients. Not even close.
And what specifically were they missing? What wasn't being captured?
They were missing that heterogeneity we talked about. The simple fact that, an 80-year-old marathon runner and an 80-year-old with multiple chronic conditions, maybe some frailty, they need vastly different approaches.
Makes sense.
The standard tools just weren't designed to pick up the complex, sort of multi-layered health issues that are common in older age. Things often lumped together as geriatric syndromes.
Okay, like what kind of things fall under that umbrella?
We're talking about stuff like significant medical problems besides the cancer itself that maybe aren't well controlled, or being on a whole bunch of medications. That's polypharmacy.
Right, lots of pills.
Which, dramatically increases the risk of drug interactions. Also, subtle declines in physical function that aren't obvious from just asking, are you active? Maybe poor nutrition, or even mild cognitive impairment that hasn't been formally diagnosed.
And the evidence back then, what did it look like?
The evidence emerging then was largely observational, descriptive studies. They were simply documenting how common these issues were.
Just counting them up, basically.
Kind of, yeah. And crucially, how often they were going completely unrecognized in older cancer patients who were just getting the standard assessment.
So the big takeaway from the 90s wasn't that they had fixed anything yet, but more like they were just shining a really bright light on the problem itself, saying, hey, look over here.
Exactly. It was about saying, look, this system is fundamentally broken because it's missing so much critical information about these patients' real capacity and their vulnerabilities. That recognition, that was huge. It proved the need for something better, for a more comprehensive assessment tool.
Okay, so armed with that understanding from the 90s, that realization that the old way wasn't working, what came next? Your sources point to the 2000s as the time for building prediction.
Right, this was a really crucial step forward. The key question evolved from, what are we missing, to something more proactive. Can identifying these issues, these geriatric syndromes, actually predict future outcomes?
Okay. So could a detailed geriatric assessment tell us which patients were at higher risk? Higher risk of what specifically?
Higher risk of things like severe complications from the cancer treatment itself, like really bad toxicity, ending up in the hospital unexpectedly, or even, unfortunately, not surviving the treatment.
How did they go about trying to prove that connection, that predictive power?
Well, they moved into more rigorous study designs. Specifically, prospective cohort studies became really important here.
Okay, how did those work?
Basically, they would perform a comprehensive GA on a group of older adults before they started their cancer treatment. Then they'd follow these patients closely over time to see who actually developed those severe problems we talked about.
And were there key players in this research?
Absolutely. A really key group driving this work was the Cancer and Aging Research Group, or CARG, notably led by the late Dr. Artie Huria, who was just a pioneer in this field.
Okay, CRG. And what did their research and others during that decade actually find? Were specific parts of the GA really predictive?
Yes, and this is where it gets really interesting, because they found that certain elements of the geriatric assessment were actually more predictive of severe chemotherapy toxicity. We're talking grade 3 to 5 toxicity, the kind that can be really serious, even life-threatening.
Okay.
They were more predictive than the patient's age or that standard performance status score alone.
Wow, hang on. More predictive than someone's actual age? That feels pretty significant. Which parts of the assessment stood out the most?
Yeah, it was a big deal. Key factors that consistently popped up included functional status, especially difficulty with what are called instrumental activities of daily living, or IADLs.
IADLs. What are those exactly?
They're these slightly more complex tasks required for living independently. Things like managing your own medications, handling finances, using transportation, shopping for groceries, preparing meals, stuff that requires more complex thinking and planning.
Gotcha. So difficulty with those tasks was a red flag. What else?
Also critical were the number and the severity of a patient's other medical conditions, their comorbidities. Nutritional status indicators, like if they'd lost weight unintentionally or had low albumin levels in their blood. And again, polypharmacy, that burden of being on many different medications.
So they went from just describing these problems in the 90s to actually in the 2000s being able to put data behind predicting the risk of severe side effects for individual patients based on these GA factors.
Precisely. And this research wasn't just academic. It directly led to the development and, importantly, the validation of practical tools. Tools like the CARG chemotoxicity tool.
Ah, you mentioned CARG earlier, so this tool uses GA data.
Yes, it takes specific inputs from the geriatric assessment and calculates an objective, personalized risk score for severe toxicity. It gives the doctor and patient a percentage likelihood.
So the significance of the 2000s was really establishing the scientific validity of GA, showing it wasn't just, a holistic approach, but a tool that could actually forecast trouble using real data. It gave oncologists data-driven insights.
Absolutely.
Yeah.
It provided a clear, evidence-based reason why looking deeper truly mattered. It showed this wasn't just nice-to-know information. It was prognostic. It could help predict the future, in a way.
That must have really changed the conversation around treating older patients. Okay, let's fast forward another 10 years into the 2010s. Your source material calls this the intervention era. This feels like the ultimate question then, right? Can actually using the results from the GA, identifying those risks and vulnerabilities, can using that information to change how we manage patients actually improve their outcomes compared to just standard care?
This was the critical pivot, yes. And it demanded the highest level of evidence we have in medicine. Randomized controlled trials,
right,
or RCTs.
Gold standard.
Exactly. It wasn't enough anymore just to show GA could predict risk. You had to prove, head-to-head, that acting on those predictions, addressing the vulnerabilities found by the GA, made a measurable positive difference for patients compared to just doing what was usually done.
Were there specific landmark trials during this time that really moved the needle?
Yes, absolutely. Several trials came out in the 2010s that were really practice-changing. The GAIN trial, conducted in the U.S., was a major one.
Okay, the GAIN trial, what did they do?
They took older patients, age 65 plus, who were about to start chemotherapy. They randomized them into two groups. One group just got the usual standard oncology care.
Okay.
The other group, the intervention group, had a geriatric assessment done. And if vulnerabilities were found like poor nutrition, risk of falls, polypharmacy, they received targeted interventions, often coordinated by a geriatric team. Things like medication adjustments, referrals to physical therapy or nutritionists, cognitive strategies, that kind of thing.
Yeah.
Based specifically on their GA results.
And the results of that GAIN trial, what did they find?
They were really quite compelling. The group that received the GA-guided interventions had significantly less severe chemotherapy toxicity.
How much less?
It was a pretty dramatic reduction. It went from 71% experiencing severe toxicity in the standard care group down to 51% in the intervention group.
Wow, a 20% absolute reduction in severe, potentially dangerous side effects just from doing the assessment and tailoring the supportive care. That's huge.
It is huge. It represents real patients experiencing less severe suffering, fewer hospitalizations potentially, And they also found other benefits in the GAIN trial. The intervention group experienced fewer falls, and they were more likely to have their chemotherapy doses adjusted appropriately based on evidence, which is crucial for safety and tolerability.
That's incredibly powerful evidence. Were there other trials showing similar things?
Yes, thankfully. Other trials helped corroborate this. The Integrate trial, which was done in Australia, showed improvements not just in reducing toxicity, but also in patients' reported quality of life. And interestingly, fewer unplanned hospital admissions in the group that got GA-guided management.
Better quality of life and staying out of the hospital more often, those are outcomes patients really care about.
Absolutely. And studies coming out of Europe around the same time, like those led by Dr. Cindy Keenis and her group, confirmed these kinds of benefits again. Fewer serious toxicities, better preservation of physical function during treatment, and higher rates of actually completing the planned chemotherapy course.
Okay, so this wave of high-quality RCT evidence, all pointing in the same direction, it seems like it would be impossible for the oncology community to ignore.
It really was. And it led to what many consider a major tipping point, the publication of the American Society of Clinical Oncology, ASCO Guidelines, in 2018.
ASCO Guidelines, okay, what did they say?
Based squarely on this strong body of evidence from the RCTs, ASCO recommended that all adults aged 65 and older who are being considered for chemotherapy should undergo a geriatric assessment.
All of them.
All of them. The purpose being explicitly to identify potential vulnerabilities and then use that information to guide their care, to guide interventions.
So that recommendation essentially cemented GA as a standard of care, didn't it?
It absolutely did. It moved it from something researchers were exploring to something that should be happening in routine practice. So the significance of the 2010s is really that definitive proof. GA isn't just a predictive tool anymore. It's a therapeutic strategy in itself. Acting on it directly improves outcomes, making cancer treatment safer, more tolerable, and truly more patient-centered for older adults.
Okay, so with the why GA is important firmly established by all that evidence, where does that leave us now? We're in the 2020s, looking ahead. Your sources describe this current period as the era of implementation, expansion, and refinement. Sounds practical?
Exactly. The focus has really shifted now from proving that GA works, the evidence for that is clear, to figuring out how to make it work seamlessly and widely in the real world.
Right.
How do we actually integrate this into busy oncology clinics? How do we apply its principles beyond just chemotherapy, which was the initial focus? And how do we make the interventions themselves, the things we do based on the GA, even better, even more targeted?
Implementation does sound like a big practical challenge. I mean, a full geriatric assessment takes time and expertise, right? That's not always easy to find in a busy cancer center.
It can, yes. A full comprehensive GA can take maybe 45 minutes to an hour, sometimes more, depending on the patient. So a key solution that's being validated and widely adopted now is using short screening tools first.
Screening tools, like a quick first pass.
Precisely.
Yeah.
There are validated tools like the G8 or the VES13. These are quick questionnaires, often just a handful of questions that can be completed in just a few minutes, sometimes even by the patient themselves in the waiting room.
And what do these screeners do?
They help quickly flag patients who are likely to be frail or have significant vulnerabilities. They basically sort patients. If you score well on the screener, you might be considered robust and maybe don't need the full time-intensive GA right away. But if the screener raises concerns...
Yeah, and you get the deeper dive, the full GA.
Exactly. It creates a practical, tiered approach. Screen everyone quickly, then do the full assessment on those who really need it. It makes implementation much more feasible in busy settings.
That makes a lot of sense. Are there other ways they're trying to make implementation easier?
Yeah, implementation science is exploring lots of models. For instance, letting patients complete parts of the GA electronically before their appointment, using what are called EPROs, electronic patient-reported outcomes.
Ah, using technology.
Right. Also, setting up dedicated geriatric oncology clinics or consultation services within cancer centers. And of course, leveraging telehealth, which became much more common recently, to conduct parts of the assessment or deliver interventions remotely.
Okay, so lots of work on the how-to. What about the expansion part? You mentioned applying GA beyond just chemotherapy.
Yes, this is a major area of growth right now. The understanding is dawning that the underlying vulnerabilities GA identifies things like functional decline, cognitive issues, poor nutrition. They're relevant no matter what kind of cancer treatment someone is getting.
So for surgery, for example?
Absolutely. For older adults undergoing major cancer surgery, GA can help predict who's at higher risk for complications like delirium longer hospital stays, or needing to go to rehab afterwards. And importantly, it can guide prehabilitation.
Prehabilitation, like rehab before the surgery.
Kind of, yeah. Using the time before surgery to implement interventions, maybe exercise programs, nutritional support, medication review aimed at getting the patient fitter and more resilient before the stress of the operation. GA helps target who needs prehab and what kind.
Interesting. What about radiation therapy?
Similar principles apply.
Yeah.
GA can help predict who might have trouble adhering to the daily radiation treatment schedule, perhaps due to transportation issues or cognitive problems identified in the GA. It can also predict who might be more likely to suffer severe side effects from radiation.
And what about the newer types of cancer therapies? Immunotherapies, targeted drugs?
That's a really hot area right now. There's a rapidly growing evidence base looking at applying GA principles there too. Early findings are starting to link frailty and other geriatric vulnerabilities identified by GA to a higher risk of experiencing those severe immune-related adverse events, the IRAEs, that can happen with checkpoint inhibitors.
Wow, so GA could even help predict serious side effects from immunotherapy.
That's the hope, and the early data looks promising. It's critical information that could help tailor treatment decisions and monitoring strategies, even for these cutting-edge therapies.
It sounds like the goals of using GA are also broadening out, maybe moving beyond just focusing on preventing toxicity or predicting survival.
Definitely. There's a strong and I think really positive movement towards focusing more on patient-centered outcomes. GA is the fantastic tool for facilitating crucial conversations between the doctor, the patient, and their family. It helps with shared decision-making. It's because it provides a clearer picture of the patient's overall health, their reserves, their potential vulnerabilities, and it often includes questions about their values and priorities. It helps ensure the treatment plan aligns with what matters most to you, the patient. Is the top priority extending life at all costs? Or is it maintaining independence, preserving cognitive function, maximizing quality of life, even if it means less aggressive treatment? GA helps bring those crucial goals into the discussion.
Making the treatment fit the person, not just the disease.
Exactly. And the final part you mentioned was refinement. Refining the interventions themselves. Yes, we know from the 2010s trials that GA-guided care overall improves outcomes. But the next level question is, what are the absolute best, most effective interventions for specific vulnerabilities found on the GA? Research is now moving towards more precision.
Can you give an example?
Sure. Instead of just generally recommending exercise for someone identified as frail before surgery, research is now testing, say, the specific type of exercise strength training versus aerobic versus balance, or the optimal dose how many times per week, for how long that is most effective in a prehabilitation program to improve surgical outcomes. We're moving beyond general recommendations towards creating precise, evidence-based prescriptions tailored to the individual's specific GA findings.
So pulling it all together, the 2020s and beyond seem to be all about making geriatric assessment a truly practical, sophisticated, and ideally universal part of high-quality cancer care for every older adult.
That's absolutely the driving force now.
Yeah.
Making it standard, making it smart, and making it reach everyone who could benefit.
Okay, let's quickly recap this remarkable journey we've traced through your source material. It's quite a story of medical progress.
It really is. It began back in the 1990s with that critical realization, that awakening, that older adults are complex, age isn't nearly enough to go on, and the old system was just missing too much crucial information.
Right, identifying the problem.
Then the 2000s brought more rigorous studies, the predictive era, proving that GA could actually forecast risk, identifying specific vulnerabilities strongly linked to severe treatment outcomes.
Establishing the science.
The 2010s delivered that definitive proof, the intervention era, with the big RCTs showing that using GA to actively guide management dramatically improves outcomes. Less toxicity, better quality of life, improved safety. That led to the ASCO Guidelines.
The proof it works.
And now, the 2020s is this era of practical implementation, figuring out the how-to, expanding GA's reach beyond chemo to surgery, radiation, even newer therapies, and constantly refining the interventions based on its findings to make them even more effective.
And what's truly fascinating here, I think, is how this isn't just some academic exercise or a change buried in research papers. For you, the listener, this whole story is profoundly important. It's about ensuring that if you, or perhaps someone you care about, is an older adult facing a cancer diagnosis, their care isn't based on just a simple number like age, but on a deep, holistic understanding of their unique biological reserve, their individual vulnerabilities, and crucially, what truly matters most to them as a person. It's ultimately about getting safer, more effective, and much more aligned care.
It really is a powerful evolution towards truly personalized medicine, especially in this often vulnerable population, a much-needed one.
And that really leaves us with something to ponder, doesn't it? If understanding an individual's full multi-domain complexity, their true biological reality that goes way beyond simple demographics, if that can have such a profound positive impact on outcomes in something as complex and high stakes as cancer treatment for older adults, well, what other areas of health, or maybe even other aspects of society, might we significantly improve by moving beyond those broad, simple labels and making the effort to truly understand the unique, complex individual?
That's a great question to end on.
Something to think about until our next deep dive.